Thank you very much. Good morning to all of you. We trust that you had a peaceful rest and you're all geared for the exciting sessions today. Please allow me to make a few announcements before we start the first session for the day. The first announcement is that the Secretariat has developed a draft call to action which will serve as an outcome document for the forum. So this draft call to action is being developed in line with the discussions that were held yesterday and the discussions that are coming up today as well. The first draft will be circulated in hard copies during the course of this morning, and we would welcome your initial review and feedback. And just to highlight that the call will be further updated in line with the discussions from the sessions that will be held today. So please, could you submit your comments to the ushers when the call has been circulated? Thank you very much. And the second announcement is rather an apology for yesterday because we had some challenges with interpretation. And for today, we would like to assure you that we have interpretation in English and in French. We are working to make sure that we will have extra interpretation services in French for the end of the day. And we would like to apologize for the challenges in the day late yesterday. Allow me now to pass the floor to Ms. Julie Kichuru, who is the founder and chief executive officer at Arimas Media Kenya. Well, you would know her as well from yesterday, but today she's moderating the first session on making universal health coverage work in Africa. How can the private sector contribute? Julie, over to you, please.
Thank you very much. Good morning, ladies and gentlemen. It's a pleasure to see you all here bright and early. And as we get started, I'd just like to get a sense of how many private sector stakeholders do we have in the room. If you are from the private sector, please put your hand right up and let's get a sense of that. Okay, interesting. Thank you. Maybe would we say about 20% of the room? This is a fascinating discussion that we have now. In the media for 18 years, I have never seen a convergence of this kind before between government, between the development world and private sector, and a willingness to work together to make true change and transformation. However, we are asking the pertinent question, how can the private sector contribute? We will perhaps address some of the challenges that we are facing. How do we ensure that integration and partnerships are working smoothly? What roles should different partners play? And what do we encourage the private sector to focus on? All those discussions will be had this morning. We have an incredible panel with us. I will start from the far end. We are happy to have all the way from Nigeria, Adesimbo Ukiri, who is CEO of Avon HealthCare. Right next to her, we have Dr. Balai Begashaw, who's Director General of the SDGs Center for Africa, and he's based right here in Kigali. Right next to him, and all the way from India, we have Jitu Jose, who is Senior Group General Manager of Apollo Hospitals Group. And seated next to him, we have Dr. Solange Hakiba, Deputy Director General of the Social Security Board of Rwanda. And right next to me, happy to have Dr. Peter Okebukola, Associate Partner, McKinsey & Company. And as we get the conversation started, I just do want to emphasize that it is now recognized that the private sector contributes in so many different ways, and that the private sector is a very wide animal. And so we are going to welcome a really in-depth engagement from the floor, because we want to understand from you, where are you placed, what do you see, what are the opportunities, and what direction for the private sector. But getting us started this morning, and I think we will start with the Nigeria experience, what we are learning there. Adesimbo, you have your finger in several pies when it comes to healthcare. And so you have a fascinating perspective or series of different perspectives. Do start to share with us what role is the private sector already playing and what more can we do to ensure that we are on the road to achieving UHC? Please start us off.
Thank you very much. I'm really pleased to be here. And sitting here this morning, I can talk about private sector participation in three areas. I'm MD of Avon Healthcare Limited, which is a health insurance company. We refer to it as an HMO, Health Management Organization. But I also wear another hat. I represent the CEO, my chairperson, who also heads Avon Medical Limited. And we, in that company, have a number of hospitals and clinics. In addition, within our group, we have the Tony Elumelu Foundation, which is a philanthropic organization, and in their own ways as well, they support, healthcare services within the country. So in these three ways, we find ourselves, playing along different areas of the value chain and different experiences. As the health insurance company, most significant contribution we make is just this ability to pull communities together, put people together, resources, risks, and ensure that when it comes to time for them to access healthcare services, they don't have to pay out of pocket. On the hospital side, we're mainly active in the primary care facilities, and we have a network of hospitals that are able to provide the services at a lower cost to the residents of the area where they are located. On the foundation side, every year there are 1,000 entrepreneurs across Africa who are given grants, and every year we find that about at least maybe 49 come from the healthcare sector. And very interesting, there's quite a popular young lady who won one of the grants last year, who is working in the area of providing blood and also has a cold chain for vaccinations in Nigeria. So it's really amazing how, even though we operate along different parts of the value chain, what we do is able to impact on this achievement of universal healthcare coverage.
Before I leave you, let me ask the all-important question. What kind of partnerships or expectations do you have from government that could make things run more effectively and really enhance participation of private sector from your perspective?
The right regulatory framework is really important. Right now in Nigeria, for instance, health insurance is not compulsory, and coverage is still very low, considering the kind of population we have and the kind of resources that the country has. So just putting legislation in place that makes health insurance compulsory will do a great deal to unlock all the potential and the opportunities that are there. What would also make us more effective in helping to drive universal health coverage is on the delivery side as well. We need that side better regulated. We need standards. Right now, all the private sector participants in the health insurance sector in Nigeria have to have an accreditation and department of their own in order to ensure that the hospitals that they contract with can actually deliver the service. So this is an area that, if the government could do something about, the Ministry of Health could work better in regulating, in accrediting and providing minimum standards for the healthcare facilities to adhere to. There's an instance where I think we've been able to very effectively work with the local government and other corporate organizations to actually push universal health coverage forward, and that's in the area of community health schemes. In Idemili, which is a rural area in eastern Nigeria, it's funny, there was a mission hospital that had been pretty run down, and Shell decided that it was going to refurbish this hospital but needed somebody to partner with to run a community health scheme for that area. And we were shortlisted amongst a number of other HMOs, and we won. So we worked with the local government and the community leaders to come up with a health scheme that would address their health needs and would move the most important indices of their health status within that community. In this instance, the government was very cooperative, gave us access to not only the local government leaders, but also the elders of the community. And the government more or less worked like the coordinator to bring all of us together. And it's a community health scheme that is still running. And Shell just refurbished the hospital and then stepped away. So we continue to work with the hospital and the community elders to continue to provide the scheme. It is paid for by the members of the community themselves, so there's sustainability, there's no subsidy. But we do find out that the wealthier members of the community might pay for other less
Right.
privileged members. So, I mean, that's an instance where collaboration and the coordination efforts of the government, I can say, has been able to.
Thank you for that. That's a fascinating discussion example, and I think it's what we need to focus on is how do we build trust so that we are able to execute such multi-stakeholder partnerships in the interests of service delivery to our communities. Dr. Balai, I come to you now, and the development goals, which it's fascinating to see them being accepted across the board by so many institutions. I recently held a gathering with the UN and private sector in Nairobi, and we had a lot of institutions present, private sector asking, tell us more about the goals and how they can benefit us and how we can benefit communities, so a willingness to participate. Health were well represented in that forum. So I want to look at the role of the SDG Center, the role of the development goals in really guiding the conversation and helping us, create a path towards achieving universal health coverage, please.
Thank you, Julie. Let me echo what my friend said here and thank the organizers to give us this opportunity. This is a great opportunity. I think I agree with you, Julie. There is unprecedented level of convergence between private sector, public sector, academia, business. I think we got to see how we should use actually this great opportunity for maximizing whatever objective that we have under the SDGs and perhaps beyond. One interesting thing here is, unlike the MDGs, I mean, we are having this feeling that, SDGs being successor for MDGs, that MDGs and SDGs have particularly the health system. The MDGs were focusing on, a few health issues that are, deadly issues, maybe issues of, huge attention in terms of their widespread and all stuffs. But when we are talking about SDGs, it has been proven as a very significant and valuable role, throughout the health delivery system in Africa and Southeast Asia, and even in the developed world. We got to see how actually this would work for, the call that we have in hand. And the second important thing is, we also have to leverage this and see how we can build the big partnership around it. Partnership between academia and the private sector means supporting research and development. Partnership between business and public service means working, on policy areas and regulatory systems in a way that each one of these parties will focus on their needs and comparative advantage, but increase the pie together. The third aspect is actually supporting private sector means, from the experience that we have now, as private sector is broadly defined that anything, but not the public kind of delivery system, it is the most actually instrumental way of reaching out the one that have not been able to be reached during all activities of the past when the public sector is trying to do it by itself. Right. So I think we got to capitalize on this. This conversation has to be how actually to build this partnership. And this conversation also has to be how each parties actually should know what's in their hand and what stake they have and what their comparative advantages, and building on that. I think one defining factor here is we got to see this thing not only as social corporate responsibility issue or support for or only from profit orientation that we all have intend to do as a private sector, but this is actually a call beyond that. This is actually a plan A in the private sector strategic plan. It's not something that we put it around the corner and actually doing it just for the sake of doing it and for gesture, but it is a plan A because what's appropriate now is what is actually appropriate from this perspective.
Right.
And whether business or private sector or public sector, we also have to do this in a responsible way. Because right now, the governance system is perhaps about transparency or good governance, but we are not really bold enough to talk about responsible governance system when it comes to this partnership. So we got to take this to the next step.
Thank you so much. I think, what we're seeing and what you're speaking to is a movement where private sector is realizing that doing good is good business. And that private sector actually is a solution provider for many of the challenges we're facing. And in that provision of a solution, there is a benefit for the private sector. And so it's fascinating to see how it is being inculcated into many organizations as part and parcel of what they do. I come to you now, Dr. Hakiba, and the Rwandan Social Security Board deals with multiple stakeholders. And in terms of the private sector, you're venturing into partnerships with pharmaceuticals, with paramedical organizations, clinical services, and so much more. Please share with us, what has your experiences been like so far in dealing with the private sector, and how can the private sector further contribute to the vision of UHC?
Thank you very much. I think the experience of, or the history of working with the private sector in Rwanda, and especially for Rwanda Social Security Board, we managed two health insurance schemes, one for the formal sector and the second one for the informal sector, has been tremendous and very interesting because it's a journey we keep building on based on the different needs that are being identified. And I can say that one of the most interesting one were for the informal sector health insurance scheme was to have the participation of the community. Usually we take the community as the beneficiary of our services, but we are emphasizing the fact that beyond being a beneficiary, the community has to be an actor in the services they receive, especially the health services. In that sense, we have involved them as civil society, as particulars, as individuals, as households, to identify the poorest among the community to be able to be covered by the health insurance, to be covered by the government subsidy. But the rest of the population is also included in the insurance scheme. So for the formal sector, that's where the most interaction with the private sector has been happening, in the sense that to expand access to care, we have been able to contract different private facilities. We have been able to contract labs to be able to deliver services. Within the community, of course, Rwanda has a history of looking into building more partnership and getting the solution from the community. In that sense, we have built, and I'm glad the CEO of EcoBank mentioned it yesterday, the health post. This is one of the root-level initiatives that have been identified and implemented. Those health posts are the first center of services that the community can benefit from, so that services are rendered across the country. Of course, the first understanding is that the government is in charge of putting up healthcare facilities. But in the reality of every day, that's not practical. And gaps are being identified across the country. So the private sector comes in and fills those gaps. Because in a sense, when you have the opportunity of paying back for the services that have been rendered to the community, then the private sector gets interested and to come in. Because they know that, in a sense, they also benefit from that those specific services. So at different level, the private sector have been supporting the government in the service delivery through the health post at community level. I can even mention that the community health workers, being individual, working voluntarily, being put together in associations, are somehow the private sector, because they come in and play a role as service prevention. And
we have been very active in Africa. The solution should be on leveraging technology, and that is where Apollo has achieved. We manage a telehealth center somewhere in Himalayas, which is at 13,000 feet above sea level. By doing that, what we actually showed is geography has become history. How you leverage technology? We have mHealth platforms, we have telehealth networks, we have the best of web-based health record management systems. And what I need to emphasize here is the more we orient ourselves on technology, the better we can achieve, because end of the day, we have to accept the fact that we don't have sufficient resources in healthcare, and especially when it comes to doctors and the medical staff available. So we need to share that. Some 10 years back, somewhere around June, we did a press meet in India. That was to announce the first successful unrelated bone marrow transplant, which was performed on a 7-year-old boy from Uganda. Why I'm sharing this thought is, India did not have this program at all. We had doctors who were trained in the best centers in the West. The National Marrow Donor Program in the US said, listen, we will help you with the search. We will ship the cord bloods to you. The doctors in Uganda said, we will do whatever you say as a protocol. We'll ensure that proper follow-up is done. Today, this boy who underwent the transplant has completed his graduation. The more we understand that healthcare is a shared responsibility and everyone has a role, the more successful we are. Thank you.
Wow, that's amazing. Peter, I come to you now, and from that really inspirational story, and so much we can learn from the East. But we've also heard from this panel the importance of policy and regulation, willingness of government to really partner with the private sector. The private sector may have some concerns about how to, invest in healthcare in areas maybe where regulation is not developed or sophisticated enough. What do we need to see in terms of government support so that private sector really can come in and fully invest in health?
Thank you very much, Julie, for that. So there are two big messages around this. The first one is for us to understand, like I think Tim said yesterday, the private sector is here to stay. It's been working with us for generations, right? And if I think about the kind of companies that we work with who want to get involved in the public in provision of healthcare delivery, I think about it like a 2x2 matrix, right? So you have on the one hand commercial or for-profit companies, on the other side of the matrix non-commercial, non-profit companies, and then think about the horizontal axis, it's basically health companies and non-health companies, right? And there are tons of companies that can fill that space, right? And everyone wants to get involved in healthcare service delivery. And the question is always around, so how do we get involved, right? But I remember Simbo said, it's across the entire value chain, from on the one hand, financing, to research, to infrastructure, to the supply chain, to nutrition, service delivery, right? And so the government is thinking about this as not a one-size-fits-all regulatory approach, but almost thinking through specifically for each of these players and where they fit in, what kind of regulatory frameworks do we need? What we're finding out increasingly is run ahead of the government, right? So, for example, things like innovation, e-health, the regulation has not yet caught up to where the private folks are already playing. And so it's almost like a game of catch-up. And so the government needs a lot of capacity building to be able to effectively regulate the private sector in those approaches. Now, to link this back to UHC, we did some analysis across multiple countries a while back, and we modeled the healthcare system in these various countries. What we found out was even the most optimally performing public health systems would only cover 60 to 70% of the population, right? Optimally functioning. You still have another 30% of the population that will never be covered by the public sector, and that gap can only be filled by the private sector from a service delivery standpoint, right? But if you think about the other parts of the value chain, you have tons of opportunities for the private sector to add value, and it's now important for the government to start thinking through, specifically, be more proactive about the regulations looking forward, because innovation never stops and waits for us to catch up.
Thank you for that. I'm going to throw two questions to the panel, and then I'm going to go to the floor. And Jitu, I think I'm going to throw this one at you first. Yesterday in the sessions, we heard
where the corporates funded the program, the health workers were given the best of training, and not just that, they were given palm tops, and today we have just moved it to Android platforms. where they know it is interesting, they report the data, there is a rating system, they were rewarded accordingly. And then the government came in and said, listen, we will support you further. And I'm happy to say that the Digital India campaign, which has started, has emphasized a lot on this. There is a social endeavor for health initiative which has been budgeted by the central government. And what happens is, end of the day, we need to understand that the economics should be worked out. The private health workers, the community health workers, they should be rewarded unless if you expect them to perform. And that comes when you have the government as well as the corporates as well as the healthcare institutions work together. And then they should have a career growth involved in it, because we always talk about private-public partnership. I would think it has to be private-public and people partnership in healthcare. And we also have these programs for our colleges. We have these student volunteering programs, which further supports those who wants to get into healthcare as a career.
Thank you. I see Bele, you want to come in?
Thank you very much, Jitu, for. I don't know why this is controversial. To me, it's a care system. And these are the community health workers that we want them to be a champion and the leading figures on preventive health system. And thanks to the technology now, we can actually, leverage their contribution using, the digital system. In fact, that's the most impacting way of perpetuating, the health impact system at the grassroots level, even when you have, a very dismal level of, secondary and tertiary health system, you can perpetuate that impact through this kind of system in place. Mm-hmm. So when we want to have this kind of system at the grassroots level, I don't know why we want, volunteers to do this job. We need to train them. We need actually to empower them, and we need to give them some clear job description because they have to fulfill the most challenging and daunting tasks, the way I mentioned earlier. And in fact, these are people who actually be volunteer to stay.
The other is service delivery. On the first part of things, an example is the warehouses in a box that have been built across many countries across the continent. The U.S. government partnering with private players and the government. So three folks in the same in that framework, with a very strong regulatory framework that makes it very clear what my role is as a private sector that protects my profits, right? And also basically protects the interests of the government and the other players. We found out that it's been working so far so good, right? That's on that side. On the other piece around service delivery, we have a lot of interesting, innovative partnerships with different players. I'll give you one example here. It's the Gates Foundation, the Dangote Foundation, and state governments in Nigeria pooling resources together to fund immunization services, right, and service delivery directly. It's worked for the last 3-4 years now. Fantastic. Just because we had a really strong framework that ring fences everyone's concerns and makes sure that we're protected. So in my mind, going forward with a very strong sense of each person's interests and then ensuring that the frameworks are in place to guard those interests will be the way to go.
Dr. Hakiba Adesimbo, yes, please come in, Adesimbo, please.
Yeah, I'm going to take us a little bit, further back and not really look at legal and regulatory, but just, if only the players will understand that they can't do it alone. They have no choice but to trust each other and come together to work to achieve this universal health coverage. I mean, if I talk about my sector, for instance, our government, and I guess many other African governments, struggle with, financing healthcare services. And we, companies such as ours, are in a unique position to pool these resources together. I mean, governments talk about, new taxes like sin taxes, but we know that, in Nigeria, definitely, a lot of our population somehow find the funds to support their telecom spend. They find the funds for premium spirits. They find the funds for all these things. And we see our role as being able to position healthcare as a lifestyle choice. No government is going to invest as much as is required in marketing and raising awareness brand building, to make people realize that healthcare is actually important enough for you to set money aside for, and it enhances your lifestyle.
But they are
areas in which the government simply doesn't have the resources or even the scope to reach all the people and educate them about healthcare and the importance of putting money aside for it. So we will act as someone who pulls these resources from the
Playing
more wealthy
a critical
people.
role.
Yeah,
Absolutely.
yeah.
That the government cannot play.
Yeah.
Please, Belay, and then Dr. Hakiba, and then.
Thank you very much. I think they put it very well, both Peter and Simbo, the regulatory framework. But again, this is not set in stone. This is a discussion that keeps going on because our population is more and more educated and aware of their health and their rights. And we are the guardians of that quality health services we are supposed to render to our population. So in that sense, I think that it's a conversation that keeps going on. When we talk about service package, it's not something that is defined and for the next 5 years.
It's evolving.
It's evolving. We need to see what are the needs, what are the new pathologies that are coming up in our population. How can we improve? Because, when, and I'm talking as an insurer, when we are entrusted by a member with its...
And more importantly, it is about, the narratives that are going around. We have very awful narratives around these issues. We're always saying that the private sector is only there for reaping profit, as if this is a sin, okay? And on the other hand, the private sector is also saying that they don't get reliable information from the public sector. They are not engaged on, policy dialogues and development. I think all these things are realities. But the point now is we are actually losing a great opportunity, not, being able to overcome this kind of cynicism. And this has to be stopped, honestly. And we can't actually unleash this resource. We can't actually unleash this opportunity without changing this kind of outlook and mindsets. We also have to change the narratives. And it's great to have some kind of clear regulatory system, but what is that without professional integrity? Okay. And where is the professional integrity? We want to see this in either sides. On the public sector, where regulatory activities are primarily responsibility, and where also we do accreditation, where we do all these kind of things, and also on the private sector, where we have actually to contribute to system building and or chipping to the training, because the private sector is using, the public sector resource when it comes to the human resource, right? Who trained all those doctors and professionals? I mean, the public sector that invest on this. So it is a win-win thing. I mean, we got to make it a win-win thing. If we don't make it a win-win thing, we will be a lose-lose, because no one is going to win under that kind of cynicism.
Thank you so much. So mindset change is critical, brings me to the floor now, and this reminds me of my favorite African saying, which is very simple but very real. No matter how many times you milk a cow, it cannot produce butter. So we have to be practical, we have to be real. I see hands already going up, gentlemen there at the back. I see a lady on this side, and if we can...
There's so much focus on primary health care, where government is looking at how much money raised from tax can pay for the vulnerable, leaving out the middle class that seeks healthcare in the private sector, who can pay premium to subsidize the government income and improve healthcare systems. So why won't the government make universal healthcare mandatory so that the private sector can compete for the lives in the informal sector and the employees paid premium, to offer the quality service that the private sector wants, so that the healthcare system will improve?
Thank you very much for that. Thank you. The lady on this side, go ahead.
Thank you. My name is Mugeni. I'm the Director of Community Health in Rwanda by Medical Center in Ministry of Health. I have just one comment. Since yesterday we talked about community health workers, the implication of community health workers in primary health care at community level. I think the first action we need to do is, first of all, in the whole country. We are lucky we are here with the regional director of WHO and some ministers from some country. We need, first of all, to institutionalize this framework, the Community Health Workers Program. We need to define the package they're supposed to deliver. In each meeting, many countries need to add package, many activities in the package offered by Community Health Workers. They are like health workers today. We are health workers here. We have salary. And we do tough shifting all time up to community health workers. Finally, the volunteer program don't work if we go with sustainable development goals today. And Rwanda achieved a lot with this program. We have a good incentive model. They are volunteer also, but we still have challenge. We need to work on challenge, and we hope all countries today can take like a call action to work on this framework, to institutionalize the framework of community.
Let me just ask before you sit down, in terms of your volunteer workers, what are the challenges that you face?
Let's say an example. We have 45,000 community health workers in each village in Rwanda today. Mm-hmm. They do many things. Injectable for family planning, treat malaria, diarrhea, pneumonia. And today, Rwanda take this model like a homegrown solution. But today, because this, let's say, incentive we give them, other authorities give another work because they do good things. I think if we continue to add social works, health work, and maybe economic work and agriculture work, they cannot provide all package.
Okay.
Yeah,
thank you very much for that. Can we just say that in terms of community health workers, I want by a show of hands. These are frontline health workers. I'm not a health professional by any means, but I would think a community health worker is absolutely critical. By a show of hands, they are qualified health workers, yes or no? If you agree that they are. No, somebody's saying no, they are not. Okay, so we will have the discussion. Let me come to the gentleman over here in the glasses. But this community health worker discussion seems to be a very important discussion that needs to be had. Go ahead, please. A little bit closer to the mic. Just get closer. Thank you. Can we get the mic to him? We can't hear him very clearly, but you're talking about the architecture of PPPs. Yes, and please introduce yourself as well.
Thank you. I'm Srinath Reddy from India, member of the IAG. I was saying that perhaps some of the ambiguity and concerns regarding the PPPs can be resolved if we redefine PPP not as partnership for, not as public-private partnership, but as partnership for public purpose. We need to define the public purpose and then identify the most suitable actors who can deliver on that particular public purpose. The broader public purpose here being UHC, but there'll be specific components of design and delivery which would have to be then redefined in terms of the nature of partnership best suited for that. And this will help us expand the conventional thinking that a PPP is only a partnership between the government and the private sector, usually the for-profit private sector. We can actually have a partnership between the government and for-profit, for not-profit, right, but also between a for-profit and another for-profit, between a not-for-profit and another not-for-profit, and between a for-profit and a not-for-profit. You have to find the right mix of partners for each task. And all of that can be accommodated in the universe of PPPs. And if we redefine PPP, neither as public-private partnership, nor as partnership for private profit, but as partnership for public purpose, then we can actually change the architecture. And the regulatory framework actually would depend upon the agreement that would be arrived at with the specific deliverables and accountability mechanisms for that particular task or deliverable. And you cannot have a broad-based regulatory architecture.
That's a fantastic point raised, and I think in that detail, you actually get delivery of a mandate, whatever that mandate might be. Please come back this way, gentlemen on the same row, and then the gentleman behind the camera. Thank you.
This is Francis Omaswa, also a member of the Independent Advisory Group. Just 2 points. First, on the private sector, an important point for us to note is that the World Health Assembly a year ago adopted a resolution on the role of the private sector working with WHO. So that's a very important point to note, and a big move from the past when the private sector was seen by WHO in a suspicious light. So we are in. Then the second one on that is that in a national health system, the ideal is to have the 3 ones. One national policy and one implementation mechanism, and then we monitor together. And the private sector should be part of a national health policy and a national health system with clearly defined roles for each of those. Mm-hmm. And when you go even down to like the district health system, the not-for-profit providers, particularly the faith-based in Africa, are very strong, providing 50-60% of health services. And they should be brought in as part of the district health team and plan together. Even the budget from the national government should be available to them for roles for which they are contracted, and so on. And the models are there for us to follow. Then if you allow me, moderator,
yes.
Community health workers.
Yes, I saw you vigorously shaking your head and saying they are not health workers. Tell us, please.
Let me stand up so that...
Yes.
Now, what you are saying about health workers, mm-hmm. It's correct. They are an essential part of the integrated primary health care system. But let's not present community health workers as the magic bullet, as I think we are trying to do. They are not. I have seen health workers being seen as the with-all in a health system. They perform beyond their competencies, they make mistakes, they become unpopular and are rejected. So community health workers are in, they are part of the integrated primary health care system, but within that system, with referral support and so on. What I fear is that some countries may be misled to stop hiring midwives and hire only community health workers. That would be a disaster. So this is very important indeed. And how to do this is written up, and WHO knows a lot about this. But yesterday I heard you, moderator, and that's why I shook my
You wanted
finger.
to emphasize. Thank you for that. Thank you for that. Let me also recognize that when we speak of private sector, it actually encompasses our faith-based organizations. It's very wide in definition. But also, let me challenge the floor. Please allow me to challenge the floor. As a journalist who has covered this continent for a very long time, that community health workers are your front line. That's the bottom line. They are in the field. They're your front line. And my fear is that there is a failure to recognize the key first line role they play. There is a failure to train them, and that's where the challenges lie in service delivery when they're not being appropriately trained. There is a failure to pay them for the work that they do appropriately, and finally there is a failure to equip them with facilities that enable them to do the work that they do. So I'm not a health professional, but I'm throwing the challenge back at you. The reality on the ground is that you need to recognize these people and reward them appropriately. Gitahi, I see you. I know you. Okay, I will allow you very briefly, and then the gentleman at the back, I see you have the mic. But let us just finish this community health workers issue, and then I come to you. Yes.
Julie, thank you. I was actually not going to speak until I heard Professor speak, who is a friend of mine and someone I respect greatly. I think the debate about community, and I see the clapping, and I always hear a lot of clapping from clinicians, especially when this issue is discussed. We are not advocating for community health workers so that they replace the people who exist in the system. It is in addition to, because the people we have in the system are based in the health facility. That is the issue. And the community health workers are going to assist those people in the facility to link to the community, because the gap between the community in Africa and the health facility is extremely big.
Right.
What we are saying is the community health workers, and the fear that Professor has is what WHO is now working on guidelines for community health workers. And I'm hoping and praying that WHO, Dela and the regional director, will have the courage to put in those guidelines that they should be trained, defined, supervised, tooled, and integrated in the health system and paid.
Absolutely. Thank you. Thank you. Gentlemen, please, from Nigeria, go ahead.
Thank you very much, Julie. And I think you've got some consensus around community health workers now, so I don't have to handle that subject. My name is Bumi Makiwa, and I'm glad to say I come from the private sector. I haven't worked in the UN system, 3 UN organizations in the past, and I'm glad to have this new position. I wanted to add 2 points to this very rich conversation by your panelists and members of the audience. I think we have a great opportunity that is probably unprecedented in the sense that we have the SDGs today. It has been mentioned, but I'd like to emphasize that the SDGs actually provides a unique opportunity for collaboration across all sectors. Remember that the SDGs were put together by all the sectors as well. And therefore, every sector has an opportunity to deliver within the SDG. And the kind of conversation we are having here, or discussion, across sectors, government, international development and development organizations, not-for-profit, and the UN is so essential. But one thing is missing. I've seen the development sector over many years, and now seeing the private sector in the past 5 years, I think the private sector is much more equipped to understand the development sector than the development sector is equipped to understand the private sector.
Very interesting.
I noticed that in the large private sector organizations, and even in the medium ones, they hire people, they research, they try to understand what is going on in development. You don't find the same kind of attitude.
So let me ask this very quickly and briefly, if you would tell us, in order for the development world to position itself to best leverage the benefits of the private sector for UHC, what must they do right now? 2
things primarily. One is have this kind of conversation that we are having across sectors. And that's why I commend WHO Afro for doing this. Right. 2, hire private sector officers.
Excellent. Thank you. Thank you.
At every level.
Thank you. I'll take the gentleman over there, yes, and then I will come to the panel and come back to the floor for another round of questions. I will be back.
Merci beaucoup. Donc, ceux qui ne comprennent pas français, vous pouvez mettre le casque. Je suis le docteur Keita.
Can I please ask for someone to pass me
il faut que j'attende le modérateur. La modératrice doit comprendre.
Sorry, if you would just give us 1 minute to get... Thank you. Sorry, allow me to take one other question as we make sure we all get our translation devices. Was there a question here in the front? 1 minute, sir. Please give us 1 minute to position ourselves. I'll take a question from the front as we prepare. Yes, go ahead, gentleman here. Thank you. You need to switch on the mic. We cannot hear you. Would you try another mic, please? Or go closer. Thank you. The mic is coming.
I can speak? No.
Thank you very much. I would like to bring a little bit the perspective from...
We can't hear you, sir. You need to put that mic right up close and speak with a lot of...
Yes.
Yes. Thank you.
Is that better now?
A bit better.
Yes. I would like actually to bring a bit the perspective from the animal health side a little bit. It's amazing how people are similar the situation, the challenges are across from the public health and the animal health.
Right.
I am actually from FAO. I'm heading the Emergency Disease Center for the Regional Office for Africa.
Yes.
Just if you allow us, starting quickly from the community animal health. For us, it is called community animal health workers. And one of the challenges has been indeed when we needed to expand community animal health so that we can increase coverage. A major challenge has been the supervision. To have the community animal health worker trained, being linked to other veterinary doctors to supervise. At one point, they went completely astray, and there was lot of lot of problems. Coming back quickly on the financing of the
Way forward. What do you suggest from your
Yes.
experience? Yes.
Yes, the experience from the how to get the private sector contribute to funding in a sustained way the animal health system. For us, we approached it from a value chain perspective. But I guess it's a bit easier from the animal health side because livestock is somehow a business. So it was easier a bit to convince using data, but it takes a lot of communication, a lot of figures to interest the private sector into investing into animal health. I guess in comparison with the investing in public health, beside all the interesting ideas that are going on, I think a fact remains. It's always, the question will be, what is there for me?
Right. What is the benefit?
As a private sector, beside the philanthropy, what is there for me to invest into the public health? And then, at the same time, the challenge is how that private sector contribution, will it affect the affordability ultimately of the cost?
Thank you.
So just to share some perspective from the animal health.
And I think it's fascinating that you said data was used in terms of animal health and how much are we using data in public health. Let me take it now.
Okay.
We are all set. Thank you, sir. Thank you for your patience.
Yeah, thank you. I come
Merci. Merci. Alors, merci Madame la modératrice. Je suis donc le docteur Keita de l'Organisation ouest-africaine de la santé, CEDEAO. Alors, je voulais intervenir dans ce débat que je trouve très riche et intéressant, mais par contre, on aborde tous les sujets au même moment sans peut-être les catégoriser. Je voudrais dire, lorsque nous parlons du secteur privé, il faudra déjà voir deux aspects. Il y a deux piliers du système de santé essentiels auxquels on fait référence. C'est la prestation des services de santé et ensuite c'est le financement des services de santé. Lorsqu'il s'agit de la prestation des services de santé, nous avons ce que nous appelons comment intégrer le secteur médical privé dans la prestation de services publics. Ça relève du rôle régalien que doit jouer le gouvernement à travers le ministère de la Santé. Donc nous avons parlé de la régularisation, de comment il faut aussi voir les aspects juridiques pour encourager le secteur médical privé à travailler dans le cadre de la santé publique. Et cela nécessite que les gouvernements soient aussi renforcés en matière de contractualisation. Et c'est un domaine aujourd'hui auquel les pays font face comme difficulté. Comment contracter le secteur médical privé pour faire le service de santé publique? Nous devons relever ce défi. Nous voyons également que dans ce secteur médical privé, il y a abus lucratifs et non lucratifs. Tout ceci doit être considéré par un système de santé qui est solide. Revenons au plan financement. Nous avons les firmes, nous avons les entreprises, nous avons donc le secteur médical privé, parlons même de les compagnies de téléphonie mobile, etc. Tout ceci sont des partenaires privés qui peuvent aussi être cooptés par le système dans le domaine du financement et d'accompagnement des politiques nationales de santé publique. Donc, nous parlons de ça. Et je terminerai par ce qui est aujourd'hui le débat concernant les actions de santé communautaire. Je pense que nous devons aussi faire un saut de mentalité pour placer cela dans le cadre de la décentralisation. Jusque maintenant, toutes les expériences que nos pays ont développées, il s'agissait de voir la santé comme d'un point de vue médical. Alors, si nous voyons la santé comme plutôt une question de promotion de la santé, donc la multisectorialité, et au niveau communautaire, nous verrons que ce ne sont pas seulement que des agents de santé communautaire qu'il faut prendre en considération, c'est tout le secteur, tous les secteurs de développement à la base qu'il faut intégrer et qui doit être placé sous le processus de décentralisation, donc le rôle crucial que les collectivités territoriales doivent jouer. Nous avons tendance de les oublier dans cette approche multisectorielle et de promotion de la santé. Merci.
Thank you. Thank you very much. I see a gentleman with a very pressing question here, and so I come to you, sir. Yes.
Okay, thank you. It's not a question, it's just to add on to what my colleague from FAO talked about from the veterinary side. I come from the World Organization for Animal Health, abbreviated OIA, and this question of community animal health workers, which is the same as community health workers in your area, has been very pressing. What we did, sometimes last year in December, we had a conference in Johannesburg, and we invited all the countries of Africa to bring their views on the community animal health workers. And an ad hoc committee has now been established to actually develop a minimum core curriculum for community animal health workers, different categories of them, under the name of veterinary paraprofessionals. Because we realize that there are some who are very highly trained, but their governments still don't recognize them. And there are those, in some countries, are those who are really poorly low trained, and they tend to do more than they should. So right now, we are now collecting data on the type of curricula, the contact hours that these people are undergoing through, and any other syllabi that can actually support their training. And we are going to come up with a standard of the minimum core curriculum for veterinary paraprofessionals of all cadres.
That's fantastic. Thank you for that example. I see you, sir. I will come back to the floor, and I'm just asking, where are the ladies? All the hands up right now. I see it. Thank you. I will come back to the floor shortly. I just want to come to the panel first and just ask, a very wide, rich range of contributions there. Some of them, and what is great is we are taking notes. And I believe all this information is being put together. So thank you for all the contributions. First of all, we should prioritize. We're being told that, let's look at this in a structured and orderly fashion. We've been given many examples of how we can work better, how we can better leverage the private sector. There's this ongoing debate about community health workers. I want each of you maybe to contribute on the questions or comments that for you were most important. And I'll start right on the end. Thank you.
Thank you very much. I'm going to start with the first question from the gentleman from Ghana. And I quite agree with you. For us to achieve universal health coverage, it would be very, very important for the governments across Africa to make participation and subscription to a health insurance plan mandatory. In Nigeria, we've been working on changing our legislation to ensure that everybody who also employs up to 5 people is now made to ensure that the members of staff and their families are subscribed to one or the other of a health insurance scheme. In addition to that, you also mentioned the middle class. I mean, that's why a company such as ours exists, because we know that for the major part, government is focused on ensuring that lower income people have access to healthcare services when they need it without facing financial ruin because of it. But then we have this burgeoning middle class population across Nigeria and across many other African countries as well, most of whom are not really contributing anything to achieving universal health coverage right now. So that is our focus, and that is the focus of many private health insurance schemes, to find out what it will take to appeal to the middle class, middle income class across our countries in a way that enables them part with money. We've also discovered through utilization data that we've gathered over the years that disease prevalence is just, it occurs much more with the lower income people. The nutrition is not so good, living conditions are not so sanitary, and we find that the middle class segment of our population tend to get sick fewer
times. That's interesting because it comes back to preventive measures and it comes back to community health workers and the work they can do around nutrition, healthy eating, and so much more. I think the development of a curriculum, Dr. Hakiba, let me come to you on this. Thank you so much. The development perhaps of a curriculum or of standards that we can say apply across the African continent for training for community health workers. Is that something that we could envision?
Thank you very much. I don't think there's one size fits all for the community health workers. Basically, we have a package they're supposed to be covering, and it's mostly prevention or some life-saving interventions that can be performed at the community level. So I think it's the foundation can be shared, but then every country has to look into it specific to make sure that the community health worker will be accepted within the community and the households and will be able to perform the services that they are being requested to perform. I would like to come back a little bit to one of the interventions of, I'm sorry, can't remember his name, but the CEO of AMREF?
Yes. Gitahi.
Yes. Gitahi, okay. He mentioned yesterday, if I'm not mistaken, that it's very important that we look into what are the different packages from the community level, but all the way to the referral hospitals. You nicely said that we shouldn't have cough and cold being treated by a super specialized doctor when he should be busy doing what he was trained for. And this package of available package at every level is important because by doing so, insurances will be able to cover. And Simbo mentioned also that health insurance should be mandatory. When a health insurance is not mandatory, the insurer cannot pool enough resources to cover its population. And therefore, interacting with the private sector becomes difficult. There is no way with a small pool of members an insurer can start venturing with private sector. And of course, we have to look into the different ways of doing that. There is packages,
I'm
there
going
is
to rush
benefits.
you. I'm going to rush you. Yes.
And that will be just my final note. It's again an ongoing conversation, and every country, every community should be able to tackle its own issues from the foundation that has been led.
Thank you very much. Peter, very briefly, we've had some excellent examples of how we can improve partnerships, how we can engage across Africa in terms of what we need to see governments do, what we want from private sector. What are your comments on some of the contributions?
Fantastic. So my comments is actually, refers to the IAG members' comments about the taxonomy of PPPs. I think that's a brilliant comment that he made, and I like the way you coined it, partnerships for public purpose. What we found, doing like a landscaping of PPPs across the continent, is a whole range of misunderstanding of this concept, and a lot of confusion about what currently exists, what policies exist today, and what do we need for the future frameworks that we need to see in place, right? For example, a lot of countries have policies for concessions for infrastructure, but less so for contracting between the for-profit and the faith-based, for example. So a lot of those policies are lacking across many countries. And I think I'm thinking about it as a much more holistic concept is the way to go.
Thank you so much. Jitu, your thoughts. I see you nodding your head, so yes.
Well, just to add to what Peter was saying, one of the models that we have successfully done in India is, in India, the health is a subject of the central government as well as the state governments. And the state governments have rolled out insurance coverage for certain areas, say for example the cardiovascular surgeries, cancer cure, etc. And the private sector came in and said, okay, listen, we will allocate a certain number of beds only to take care of that. And here there is no cost that has been factored because it's a service that is offered to the government at the basic price. And that way the participation has become an easy, and the format is working very well, especially in the southern parts of India. So that is again one of the strong steps taken by the government in India to move towards universal health coverage by saying that, okay, listen, I'm getting an additional bed capacity through the private sector, and what would possibly be catering to an underserved segment who cannot otherwise afford to take care in a JCI accredited hospital for a bypass surgery. So that is one part of it. The second part of it is, as my friends were saying, the government's policy should change, and because the government trusts the private sector when it comes to the pharmaceuticals, when it comes to the diagnostic, the consumables, but when it comes to the healthcare delivery per se, for profit is not acceptable. But you need to have sustainable models, and in this,
we need to be realistic.
We need to be realistic, and I would suggest the WHO to look at creating a panel format where the private participation comes in, and you have at least an online networking system where this is shared. Because we see, again, a lot of good works happen in silos. It's not connected.
Thank you very much. Balai, I'll come to you before going back to the floor.
Just want to focus on two issues. First, I want
very quickly, please. Thank you.
First, I want to re-emphasize on the need for having in place, standardized and vigilant, community extension. Community health worker system. I think it's very difficult actually to talk about the universal health system without having that kind of infrastructure in place. Mm-hmm. I think that's the only way that we ensure universality, right. and reaching out actually the vulnerable group of the population segment. Secondly, if we want to talk about data, I think that's where data are generated, and we have to make sure that our community health workers have some kind of capacity actually to hook themselves on this important task. Right. Third, all big campaigns now, including 90-90-90, 95-95 around HIV, and also other educative and promotional campaign around health, they are accounting the availability of this infrastructure in place. Mm-hmm. So I think all this indicates that this is not an option. It is something compulsory that we have to.
It is
imperative. If we don't want, if we are not able to make it work, it is up to us to actually look ourselves internally and make sure that it is working. Otherwise, it's not something that we would really leave it like this. It is extremely important and indispensable in this process.
Thank you. Thank you.
The second short comment that I want to make is, I think it's well said earlier about how the SDGs actually provide opportunities. Again, I want to reemphasize on this. The Agenda 2030 actually embroidered health as a fundamental human right. Mm-hmm. I think this is the maximum that you can actually underpin and support something through this level of commitment. Right. When we have this level of commitment, again, we should not lose this opportunity. And whether the universal health coverage or other very proactive health-based initiatives, I think it's time actually to promote them. It's time also to push this agenda to the maximum. Perhaps one other thing that we might also need to look into is in health now, we defined it very clearly that it is the nexus that makes a big difference. It is not only what we do on health, but it's what we do on issues like poverty reduction, nutrition, and education and gender equality. I think when we are trying to bring all these things as a nexus, there should be some kind of mechanism around health that really underpin and interface and interweave all these things toward these very defined goals. And SDG has provided that us, and we need to look into this thing very consciously.
I think, never before have we had a stakeholder or a center sitting there able to facilitate this nexus. So it's fantastic to have the SDG center there. I think the final words will come from the floor. Yes, sir, I see you with the mic, and then the lady on this end. And I wish I could take more. Let's see. Please make it as brief as possible. Thank you.
Thank you very much.
Yes, Dr. Moeti as well. Yes. Oh, yes. Okay, thank you. Please go ahead.
Thank you very much. I wanted to add my voice to the to the contributions on the community health
As
workers.
quickly as possible, sir.
And
give
that
us your name and go for it.
Yoswa Dambisia from the East Central Southern Africa Health Community.
Thank you.
The WHO has set in process a number of mechanisms to formalize and develop guidelines for community health workers. I happen to be a member of the Guideline Development Group.
Excellent.
And I'm aware that my brother, Dr. Githingi, my elder Professor Maswa have already made submissions to our group. So the debate on community health workers will not be solved here, but perhaps elsewhere after we have digested such contributions and contributions from other stakeholders around the world.
Thank you so much.
Suffice to say that we are unlikely to come up with a one-size-fits-all.
Thank you very much for that, sir. We really appreciate that. Yes, please go ahead. And then I come to the front. And then the lady behind you, then you, sir. Yes. Please move a bit closer to the mic. Thank you. Under our description, you actually fall within private sector, but we shall have more engagement on that. Our member from Ethiopia, please. The floor is yours. Thank you. Thank you. So Ethiopia, they're sharing their example, and what they've done is saying, a week of training does not make someone a community health worker. In Ethiopia, these are high school graduates who then go through a 15-month program and are then employed as community health workers. And thank you for that example. Dr. Moeti, you have the final word. Thank you. Thank you very much for that. I would love to come back to the panel, but we literally have to close. Thank you, Dr. Moeti, for giving us direction on the way forward. Just to share the fact that it is exciting to see the private sector step up, willing to be engaged, and to encourage all other partners to understand that private sector is not necessarily exploitative, that it is efficient, that it builds effectiveness into models. And I think once you have clearly defined structures and targets together, we can achieve so much. One of my African heroes, Kwame Nkrumah, he shares many thoughts, and he has a quote that says, "Action without thought is empty, but thought without action is blind." If we come together, and as we were told yesterday in the public health session by Dr. Emmanuel, we must make decisions. We must work together, we must act, we must strategize, we must think clearly, and it's not going to be easy. My hope is that WHO, walking away from here, is able to start some sectoral groups to take further discussions. And in fact, we have not discussed media as a partner here, and yet yesterday the member from Sierra Leone told us communication was a huge challenge during the Ebola crisis. So I encourage you to even welcome partners from media and other organizations. I am encouraged by the momentum that I see building. I think the development goals have given us direction forward. It is ambitious to believe that we can achieve UHC, but I believe we can. Can you tell me, do you think we can get there? Honestly, those who do, please put your hand up. So, we have a few hands up, still not enough. And so our work is immense. I want to thank you all for being here, because whether you believe we can achieve it or not, you have come here and you are a stakeholder on the journey. And so let's put our hands together and work together to ensure that private sector is relevant and is taking us towards UHC. Thank you so much to our panelists. Please let's give them a warm round of applause. And thank you to all of you for joining this session. Have a good day. Thank you.
Thank you. Thank you very much, Julie. Can the panelists please wait for their photograph? Just a few announcements. We will break for coffee, a 30-minute break until 11 o'clock. And during this break, you are encouraged to visit the various booths that are in the foyer. Please also be reminded to pick up the first draft of the call to action, which is available on your way out in English, French, and Portuguese. Please provide your comments to the ushers before you go for lunch. Thank you and enjoy the break.